I just encourage you to think about many things that you probably already know as to how to foster the voice in the relationship in another who's suffering. For example, what about establishing rapport? Just being on the same wavelength, really listening to that person. And not just listening to the words themselves, but what's behind the words, what's between the words, what's above the words, before the words. Really listening to the tone of voice, looking at the affect, the expressions, to try to decipher what that person is actually experiencing. And a key thing here is, and this comes from Janice Morris's work. She's a Canadian nurse that has done a lot with some suffering, especially in traumatic areas. But she talks about how to respond to somebody, even in terms of your own affect, your own feeling. And of importance when somebody's in deep suffering is not to be overly cheerful. Do not be too cheerful. This makes people more depressed. So make sure that you're monitoring your own emotions, your own affect, your own emotional response to this person. So often we just say, cheer up, you know, get going, you got to pull yourself up by the bootstraps and get going here. But sometimes that's not the best response for some people who are really, really suffering with depression. And again, you know, one size doesn't fit all here for everybody. So you have to just really be tuned in to what is going to be most helpful for each individual. Okay, what I'm showing you here is called a model of consolation. This comes out of my Swedish colleagues. About 10 years ago, the country of Sweden in their national health policy, followed the Hippocratic Oath, and they said that health professionals in Sweden will focus on cure, palliative care, and also consolation, and that is right from the Hippocratic Oath. And so they asked the question, well, what is consolation? What is it like? And how do we mediate consolation? And so my colleagues came up with this model, which has been used in various countries and in various research. It's called a model of consolation, and I consider it a response to suffering. And I have a little time to go into just an overview of it now, but I really encourage you to just seek out the article. It's fairly available on internet, and to read more about this, as well as the multiple research studies that it has been related to. I've used this model in my research in looking at nurses' responses to patients who are suicidal, and I find that it really can provide some guidelines to help nurses respond to patients who are deeply depressed and suicidal. So a key thing here is just to kind of imagine yourself here, that we have one side here where we have the sufferer, and we have another side who's the mediator of consolation. And again, it's called a mediator because I cannot console you. I can only mediate consolation. Consolation may come out of that for your experience. I can only mediate or try to foster, facilitate some comfort, solace, consolation. And the important thing here is that the mediator of consolation, which is you and I, be open, be very present and available, provide adequate time and space, you know, get the environment, the milieu ready, and be very daring and courageous to listen. The key thing is that we need to come close to suffering. Often we want to stand away from it, right? It's no fun, we don't know how to respond, we don't want to have anything to do with this, it might make it worse. But we want to come close to suffering, and we know that from our research, that we need to open up ourselves to become ready to meet a person who is suffering, somebody in depression or other ways, and to try to connect with them. And the Swedish model calls this being in communion. They look at communion as a unity of communication, from their translation. It goes back to a philosopher called Martin Buber, who talks about I-thou relationships, which is a shared relationship, a mutual relationship. And it's the key thing here is not knowing all kinds of facts in your head. The key thing is a shared affective state where actually I am feeling and empathizing with this person and feeling some of their pain, their suffering. That's very important because this is the way that the wound is uncovered. It's only through sharing and connecting with this person at that level that you can uncover the wound, and then uncovering the wound can help move forward into some healing, which is a shifted perspective from really a darkness to a lightness. So I just encourage you to look at this. I find it really exciting. It has really been helpful to healthcare providers in just kind of focusing on, you know, how can we encounter these people who are in deep suffering from depression. What we want to come out of constellation and mediating constellation is this experience of hope. Hope is an extremely vital aspect of our lives. And hope is something that has something to do with the future, a positive expectation, some goal that we're working towards. And there's quite a bit of research that's on hope. A couple scales out there, if you want to look at how to even measure hope or assess for it, is the Hearth Hope Scale, which has been used on people 75 years and older. And there's also a Geriatric Hopeless Scale. These have been translated into various languages and are used internationally. Another possibility is the protective factor of resilience. A recent study by Lena Alex, and she's a Swedish colleague, she studied resilience among very old men and very old women. It's a new publication here just as of last year. And she looked at high resilience as perseverance, self-reliance, meaningfulness, existential aloneness. Her design was qualitative and quantitative. She studied 85-year-olds. She looked at their stories, their narrative interviews, and she used the resilience scale, which was developed by our own Dr. Gail Wanghild, who is the co-inventor of that scale, and Gail's here today. I thank her for her contributions to resilience and how it's relating to depression. The themes that were found in this study were feeling connected, feeling independent, creating meaning. Kind of makes sense, doesn't it? Kind of hear some of the same themes coming out over and over again. But what's also interesting is a new book that's out by some physicians. It sounds like physicians are interested in resilience too, as well as our nurses. And this is a book by several doctors on resilience and aging. And this book talks about resilience as a motivating force and intuitive process by which individuals rely on an innate moral framework that facilitates energy and an experience of control and freedom. What's interesting to me in this book by these physicians is that they are coming out with clinical guidelines for resilience because they are seeing that it's so important to health. It's very exciting. Earlier I mentioned about safety. Safety concerns relate to depression. An underlying thing is to always be concerned about safety. And so a protective environment, of course, is always important. Physical environment as well as an emotional environment. I'd like to just take a few moments to address the protective environment in terms of the patient's risk for self-harm. As I mentioned, suicide is a high risk among depressed people. Depression is the hallmark symptom that leads you to think about possible self-harm. And there are many materials that are available at the website that I've given you. This is the American Foundation for Suicide Prevention. We have a chapter here in Montana of which I'm involved, and you can find out about that chapter on this website as well as the national website. There's many brochures, many videos, all kinds of materials that are available for you to look at, to learn from yourself, to offer to families, to look at in your organization. A key thing just to remember here, though, as if somebody is really depressed and you notice this meaningfulness, this purposelessness, is to ask them the question. If we just ask the question, it can save a life. Because depression can be fatal, depression can be terminal, and people can die of depression. So ask them the question. Be courageous enough to just stand up and ask them the question. What do you have to look forward to? You know, what is good about your life? Are you thinking that death is something that is appealing to you? Are you thinking about dying? Would you, you know, think about harming yourself? Just some simple questions. You have to be really courageous to do that. But I believe in all of our settings, wherever we are, we need to be asking that question because safety is so critical, and we can save a life. Suicide is preventable. It is one of the most preventable public health problems we have, and you can do this. So a real possibility is to save a life, and that's pretty exciting. I've mentioned about nutrition. Many times our elderly don't want to eat, so nutrition is certainly an is something that we can look at in terms of helping them to live well, monitoring their weight, their intake and output, their bowel function and food allergies. All of those are important in terms of looking at the well-being and minimizing depression. What's pretty exciting is what's coming out in the arena of targeted nutrients. And during my time in Alaska, I worked with some doctors, and we were using targeted nutrients in our inpatient settings for psych, for depressed patients. So this is not something that's far out, but we're using it for patient care. And these include the following, like the vitamin Bs, B6 and B12. B6 is an emotional stabilizer. B12 diminishes with aging, so what happens in this aged body? Maybe they need some B12. I always say that vitamin Bs beat the blues for all of us, so I encourage you to look at your vitamin B intake. And it's interesting that the probiotics and prebiotics, which you can just take over the counter, facilitate in making vitamin B. So sometimes you need to have more digestive assistance in utilizing vitamin Bs. There are certain amino acids. These are precursors to the amino acids. There are 5-HTP or 5-hydroxytryptophan, tyrosine, phenylalanine, and GABA, which is gamma-aminobutyric acid. These two are things that you can buy at the health food store, for example, but you should be looking at the balance of what you're doing in terms of some practitioner helping you with that. And then SAMI is another thing you might be familiar with. You can buy it over the counter at Costco or any drugstore, and that also helps in metabolizing norepinephrine, dopamine, and serotonin. So we're finding out there's a lot of implications with nutrients that we can use to help people feel well. And then this is from the National Center for Complementary and Alternative Medicine. You can go on their website. You can find a lot of evidence-based information about nutrition, herbal remedies. For example, St. John's wort and valerian are a couple that are mentioned on this website. Just note that St. John's wort has been found effective, according to the website, for mild depression. So it certainly depends on what range, where you're at in that depression range. Of concern, though, if you start mixing these things, is you want to be aware of what's called serotonergic syndrome, and that's because all of these herbs, as well as some of the nutrients, as well as if you're adding any of the medications, they all can relate to affecting the neurotransmitter serotonin. And so there are some danger signs that you need to be aware of here too, such as tremors, hypertonicity, autonomic dysfunction, hypothermia, and even death. So it's important that you certainly have somebody help you balance these things. These are all just possibilities that we're imagining here for dealing with depression. Oops, what did we do? Okay, so sleep is another thing, and I know Julie Pullen was focusing on sleep and the issue of insomnia, and that relates a lot to our elderly. We know that stage 3 and stage 4 sleep diminish with age, and that 25% of our elderly have persistent insomnia.